welcome you all for this session. When the going gets tough, the tough get going. So it's a video-based session, and this is the 27th season, and we have been doing it for last many years. And so in this session, the presenter will be showing a tough, challenging situation, and we all will be discussing the case. We can stop the presenter at any moment we like and discuss what other the things could have been done, to have a different outcome or like that. So it's a very interactive kind of session and not a didactic lecture. And to present the first case, I'll invite Dr. Kumar Doctor, a good friend, a prolific surgeon, we all know. And he has won many awards in international and national conference. And we all know that he comes up with some interesting cases every time. So let's see what he is going to show today. And I'll request Dr. Jagatram sir and Dr. Harshvardhan to discuss this case with him. Yeah. Dr. Kumar.
I think I'm the add-on now, just to fill in the gap. Every time we decide what should we do next year or new in every year. So we decide drink less, find love, enjoy life, take a trip, join gym, save money. Everyone wants something new in their life in the next year to come, and this is a new year. So this IOL came like this. Now I don't know how many of you have seen a lens like this. As you might know that this is a lens which some of you might not have seen at all, okay? So you see dialing holes, okay? And you see a 3-piece IOL. So those who are senior would have seen this lens. Now this lens is subluxated. So what are your options at this stage? I'm not able to have my control because this is playing a dual control. So I would actually like to pause this here.
Play the playing slideshow.
It is playing slideshow only, but it is showing me dual control. Like this it's coming. So I want to get that off. Mirroring करना पड़ेगा.
No, वो presentation. You have control?
Yeah.
Okay, perfect.
Sorry. So I'm just going to take it ahead. So just for your information, this is a subluxated IOL. It's got a 3-piece IOL. You see dialing holes. So what will you do at this stage? Tell me, what is your thought process? Now you have a large iridectomy. What would you do in such a scenario? Let's discuss this. Then I'll just play what I did. 35 years back, 40 years back. I won't tell you. You will see the lens what you're seeing. So sir knows, you won't know because I don't know whether you were born. The lens was born before you. Correct. So this is a 3-piece IOL. And what would you think is, this is all the pupil dilates, okay? The pupil doesn't dilate more than this. So what are your options? You explant, you do a glued, you do a posterior iris clip. You can do so many options, right? So the question is now what to do. So this is what I decided to do. Give support from the back and then went ahead and got that in and made the flaps, okay? So I was preparing to explant this IOL and do a glued IOL, okay? Recently I did a T-Flex actually just yesterday, and it's a fantastic lens to use, made by Madhivaran. Some of you might not know. It's better than a glued because you don't have to do all this. Here I made a flap, and now I'm going ahead. Now this pupil doesn't dilate more. So if the pupil doesn't dilate more than this, you can't use a Melugan ring or you can't use a Bhattacharya ring, okay? Because you need to look at the axis all around. So what are your options now? So you have a 3-piece IOL with dialing holes. These holes that you see in the optic, these optics are 6.5 millimeter and they had dialing holes. So in the Purana Jamana, we used to put a Sinsky hook through these dialing holes and then dial the lens into the bag or wherever it was. So that time we used to do ECC do an envelope technique, put this lens into the bag. Technically the lens would still go into the bag, but these holes used to be used for dialing. Now this is all the pupil dilates. Now what are your options at this stage? So what I did was, of course you have to put hooks, and that will give you enough exposure. And you can see that I'm using a micro grasping forceps and centering this, and then doing a vitrectomy, removing all the vitreous in front of the IOL and around the IOL. Very important that you remove all the stretches or all the pulls that is happening in the anterior chamber. And now what are your options? My main thought was either remove this, or as I said, put another glued IOL or whatever it is, right? Now some of you might not know this, so we won't waste time. This is a solid PMMA IOL. It's not a foldable IOL. So you can't cut this IOL. So some people think that you can cut this, you can't cut this. So, and these are not modified J, they are not C, but they are modified C. Now modified C loops are large loops, okay? To bring them out and do a glue on this is not all that easy. Like a modified J has a shorter curvature, to hold the tip and bring it out is much easier than doing that in a modified C. So you can see that I'm holding the lens and centering this lens and brought it to the AC. So you can see the loop, they are big, okay? So this is a design, must be 30-35 years back. The idea here was now what to do. So I decided to glue the same IOL, okay? Now one more thing, you can see that I brought the IOL out in the same direction, and now you just make, so it's very important that when you want to glue an IOL, the direction of the haptic has to be this. It can't be other way around. To my luck, I brought this IOL out which was in the same direction I wanted it to be. So if it is other way around, you have to flip it in the AC. So sometimes you may need to do that. So here I'm going ahead. Now it's very difficult to do a handshake technique. I'm just removing the vitreous from all around the IOL. Once I've done that, now you remove the vitreous from all directions. Make sure that there's no vitreous in the AC at all. And again go through the same port, remove all the vitreous from behind the IOL. And now we have to do a handshake technique, and as I mentioned, this is difficult, only reason being is the shape of the haptic that is there. So this was just removal of all the, so through multiple ports now I'm doing a handshake technique, just going to do that if possible, and then go ahead and do this, just make sure that the forceps are working and goes in properly. And now I'm going to hold the haptic, and you can see how big the haptic is. You can see these are modified C, more than a modified C. And now I'm going in, and then you have to hold it. Now this will bend a bit when you come out. You don't have to worry, but you have a large haptic. So itself is going to center the IOL. So here we go ahead and bring it out. So you saw that it bent a bit, it nicked a bit, but it's fine. The same way I do on the other side, and then center this IOL and bring it out. So you can see that once I've done the other side too, just tuck the haptic inside, just like a typical glued IOL as taught to us by Dr. Amar Agarwal. And once you've done that, again the same trick, once you've done that, remove all the, so basically here was no IOL calculations, yeah? You can, there's no harm, yeah. Yeah, you can cut it a bit in the AC itself, make it like a modified J, and then hold the tip and bring it out. You're right, it could be possible. Sometimes, you know, it breaks coming out, and then you can knock it out itself. So here I've gone ahead and just brought and then tucked the IOL. And then, so big advantage here is there's no explantation, there's no cutting of IOL, there's no IOL power calculation, because the patient was very, very happy for so many years to come. It's just a subluxated IOL, which because of the new technique that is access to us, we can just center it quite well. I'll just show one more case if it is possible. This is the last case I'll show, then he can take over. So this case was again operated by me 30 years back. You can see that IOL is not seen, but you can see on B scan that there is an IOL, no history of trauma. Suddenly the patient comes, and what are our options? Okay, so when you don't see an IOL, so just for your information, I don't know, sir, Professor Jagatram can tell us, when you don't see an IOL, you can only see the IOL on a B scan, it's sitting down in the vitreous. You really can't see the design of the IOL. So you can only know that yes, the IOL is inside, but you don't know whether it's a single piece, it's a 3-piece, or whatever it is, it's with the bag, without the bag. Really, we can't tell all this in detail. So this patient came to me like this, sudden loss of history, loss of vision. You can see that you can just see something dangling. So here I go ahead and again make the port. Once the port is made, I start doing my vitrectomy. So what would you do at this stage? So I decided that yes, I have to explant whatever is inside and do another IOL, which is a glued IOL that is possible. So that's the preparation that I really did, and made my flaps as advised and started my vitrectomy. To my luck, when I started vitrectomy, the IOL suddenly comes up. Okay. So now if you got your IOL and you can see that it is a 3-piece IOL, what will you do next? You're good at copying, huh? So here the trick was, yes, I held on to it. Again, it's the 4 dialing holes in the optic. But now look at the way I've got the IOL out. Okay. What you have to note is the direction of the haptic. Okay. The direction of the haptic is not what we desire, because these are, just for your information, angulated IOLs. These IOLs were old IOLs, so they had a 10-degree angulation. So if you fit them upside down, they are forward 10 degree. Otherwise, normally they are backward 10 degree. Okay. So this is the same IOL which you saw. You must be wondering why I'm having all of them coming back to me. But well, so you can see now this IOL, I've got it out in the AC, but look at the direction of the haptics. Okay. Now what is your option here? Okay. Now the direction of the haptic is upside down. You have your dialing holes. You have the whole IOL in the AC, and the trick is the same. I want to refit the same IOL. Can you fit this in this direction? The answer is no, because you'll have a forward angulation. So what I did was I flipped this IOL in the AC. So I took a Sinskey hook on one side, the iris repository on the other side, and I flipped this IOL to change the direction of the haptics. Once I've done that, the game is over. Everything is done and dusted. I'm going ahead and then making my flaps, doing the same procedure, bringing the haptics out and refitting. So what happened here was, through 2.75 millimeter side ports, I got the IOL out. No large incision, no explantation, no IOL calculation. Same IOL back into the position, and patient is extremely happy. And this is how you just take it back, and then that is done, and then put the IOL, put the glue, and the story is over. Thank you for the opportunity, Harshul.
Thank you. Thank you so much, Dr. Kumar, for showing these wonderful cases. Any questions? Yes, ma'am, please. Give a mic here, please. एक mic इधर दे दीजिए.
I want to ask whether you had a bag in the first case?
No.
There's no bag. The other question is, in such cases, is just anterior vitrectomy enough, because it sometimes tends to
pull. So you saw in the first case I did vitreous removal from behind the IOL, in front of the IOL. It's very, very important that when we glue an IOL, the area, if there is a bag, that area should have no bag. Otherwise, you'll be pulling the zonios when you go in and go out.
Correct.
So that area, we have to do a vitrectomy and remove everything from that area, what is there ever possible.
Okay. So what had the previous surgeon done? He had just placed the IOL?
It was at my place only. So I feel that lens must have gone in the sulcus.
Okay.
So those jamanas we used to do ECC, and then the lens must have been put in the sulcus, and then over time it was a subluxation, so the whole lens went down.
Okay.
So when we do the vitrectomy, all of the bag and everything just goes out quite easily. And the next case, of course, was a complete dislocation.
So I have one doubt. This
Yes.
lens is foldable or
Non-foldable.
non-foldable?
Yeah, it's a
But it's
3-piece.
haptic, but haptic is.
Yeah, so it's a 3-piece solid PMMA non-foldable.
But it is bit dangerous to keep the lens in AC.
Not really, because with the new viscoelastics, we create our space. There is no posterior capsule to look after.
That
So
is
all you have
okay.
to look after is the endothelium.
But
So all you have to do is push the lens down and flip it. Nothing
But
happens.
in case of presence of PC, intact
It's
PC,
difficult.
it is dangerous to flip.
Yeah, it's difficult.
Thank you.
Yeah.
Thank you.
Dr. Kumar, this is, I think, excellent surgery.
Thank you, sir.
Both cases are similar.
Yeah.
We have seen these IOL.
Yes.
This is 100% when it is a hole in the optic, it means it is a PMM IOL. Usually, till date, I have not seen any hydrophobic acrylic IOL
Yeah.
where there is hole in the optic.
Yes.
Or have you seen?
No.
So
They were
that
all
is-
solid IOLs.
Yeah.
There is a doubt because some surgeon has done hydrophobic lens surgery, but while I saw there is a hole, there is a hole, and again there is a 4 hole. That's why I asked this question.
Yeah. So these are solid PMMA IOLs.
Yeah.
They cannot be folded. But there is recently a technique shown by somebody in the US where they are hydrophilic IOLs. and he's invented a punch. So you can actually punch the haptic or the optic and make a small 0.5 millimeter hole to suture the IOL into the sulcus. So that's
So I think you have done excellent job. But while you showed the first image in the first case,
Welcome.
that time what you were saying that what will you do? That time I thought that I will dilate the pupil and whatever I will see the capsular support and dial
refix
this
it.
IOL because haptics are long haptics. But once after you showed that after AIOCMTC you showed that there was no capsular support.
Yes.
Then I agree with you with your finding that okay, you have to go ahead with the
Refixing.
sutureless that glued IOL.
Yeah.
I think this is perfectly done, and you have done nice vitrectomy also. And regarding cutting the haptic in the inside is not, I think that is not a better option. It is best to whatever intact haptics are there, they should be brought outside. But I think it is better to bury them as you buried it into sclera.
Yeah.
So it was very nicely done.
Thank you.
Could we have put a Prolene suture and just pull the haptic?
You can do that.
That could have been like more easy for me rather than doing all this.
Difficult for me.
Thank you so much, Dr. Kumar. And I think Dr. Rajesh is here, the most busy person we know in any AIOC conference. And thank you so much, Dr. Rajesh, for making it for this session. And I'll request Dr. Rajesh to present his case. He has the parallel session running in another hall.
I'll just show two scenarios, small scenarios. One was regarding an ICL which was implanted inverted. So this is an ICL. The basic idea is that when you are implanting the ICL, you have to be absolutely sure that the hole should be there on the leading foot plate on the left side. And that is something here I am just trying to pull the cartridge. Again, another message that I would like to say, that you should pull the cartridge and not the forceps while loading the ICL. And then as I'm trying to put it by mistake, it's my mistake only, but jerkily when you keep rushing from one table to the other, it happens sometimes, and then finally I'm not able to rotate it. Many times if it's partly there, you can rotate the hand, and I'll just stop here. Many times when it is going in inverted position, you can rotate the hand and manage with the second instrument, and you can do it. I mean, this is something which you have been doing it, but sometimes it happens that it flips and it goes inverted. Now, if it's inverted, then in that case, one can manipulate. I remember Dr. Kumar had a series of cases wherein he had just rotated inside. But when you are, teaching your postgraduates and senior residents, you have to do the most ideal thing. And the most ideal management is that you have to explant it. So you can easily explant it. Now, while explantation, as you could see here, you can use two McPherson's. Hold one. The foot plate should not be held in the middle. It should be held at one side. And then it squeezes out and it comes out easily. And with the help of two instruments, you can take it out. It doesn't get damaged at all. 1 minute. You were explanting it. Yeah. I just got a thought. When you were half in and half out, it had folded upon itself. Yeah. Can you push it back in and it reverts? Is there only? No, that's what I said. That, if it's half open and you see that it is like this, so you can rotate your hand. That's what I was.
Do a reverse on your video.
Okay.
And
Yeah.
when it came out, it came like a sandwich.
Yeah.
When you push it back in, it opens like a right way. See your video.
Yeah.
It's just a thought. See, now stop.
Yeah. Yes, that can be done. That can be done, but this is something. When almost 3/4 was out, the problem is this, that you will have to push it with the forceps, which is not advisable and which is not advocated, which cannot be advocated. That is the problem. So as I said that, I can say here, I can tell everyone that I have done that series 8 cases, I know your series, wherein you just inverted inside. The only problem is that it can have some effect on endothelium, which may not manifest at that point of time, but it may manifest later in his later age. So that is why it is not advisable. It is said that you can easily take it out and then re-implant it. And that is what we did, and we took it out. And that is what we have to, tell the students also, that this is what is the ideal method that we should do. And then it was re-implanted and it went well. So as you can see here, the hole is on the right side now, and I'm going slow. 90% of the chances when you are rushing with your work, it happens. And out of those, about 80% of the times, if you rotate your hand, and with the second instrument you can just stabilize the remaining part of the ICL, you can still make it proper. But sometimes it can happen. So it happens to teach us, and that is what I thought that I should present this video to all of you. That is one. The other thing which I wanted to present, a very small one. This is a case of operated glued IOL actually, which is decentered because the patient probably patient had a trauma. Now, even if you have a mild trauma, most of the times if the haptics are well tucked, usually with minor trauma it doesn't get dislodged. But if the haptics have not been very well tucked, then in that case it may slip, and that is the problem. So I was not aware exactly what happened, because the case was operated by one of our senior residents. And when this patient came, then she panicked. She told that, oh, it was fixed, but how to fix it now, because there will be fibrosis around. Now, it is a fact that there will be fibrosis around, so that is why if we have to tuck it in again, because this haptic is out. So here we have to create a fresh flap. This is what I would like to show. Because once there is fibrosis, one should not try to, you can't pull the same flap. So you create a fresh flap and a sclerotomy, hold the tip of the haptic and take it in, take it out. And then you tuck it in. And once you tuck the haptic, put fibrin glue and replace the scleral flap, and that is it. So I thought these are the two things that I would like to present, and we would just like to know your opinion, what better we can do.
One thought was that when we do a good IOL, we want it exactly 180 degrees.
Absolutely.
Now the original flap that was there is already whatever has happened, and you created a new one.
Yeah.
So the new one that you created to tuck it was not exactly 180 degree across.
Mm-hmm.
Of course, it was a normal foldable monofocal IOL, so it really doesn't matter. But technically, it will decenter.
Yeah. No, it does matter. The only thing that we can do is that if we draw a line bisecting half of the IOL and take it towards the sclera, then we are reasonably sure that we are almost diametrically opposite. So that is what I follow. But exactly 100% you can't be absolutely sure, because you don't know the margins of the flap. But if you make a straight line bisecting the IOL and taking it up to the sclera, that is the midpoint of the flap. That is what I keep.
Could you have done a Yamane on one side and nothing on the other?
No, I would not do that, because that will decenter. Because here, part of haptic is tucked into the sclera, and here you are doing Yamane, so you have to cut the haptic first, and then you have to center it. And somehow, to tell you frankly, I'm not very much fond of Yamane, because I have seen that the pseudophagodonesis is higher in Yamane.
Yeah, switch on this mic, please.
I think you have done excellent job. The first case where it was other way around,
Sir.
there was no other way than to take it out and re-implant it.
Sir.
Otherwise, while it was coming almost 3/4, I think there was a option which
Yeah.
Kumar also said that okay,
Yeah.
whether. But I think easier at that point of time, I think major part of the lens was out.
Yeah.
So I think that was the best
yeah.
way which we can do.
At
And
that
it can
time, sir, we
have
had to push with the MacPherson forces
Yeah,
that
yeah.
can damage the ICL
yeah,
also.
it can damage. I think
Yeah.
damage is the.
Yeah.
If it is a IOL, then it is fine. But
Yeah.
when it is a ICL, so you can't, I think, afford to damage it.
Sir.
I think that is the best way. In the second case, very nicely, I think haptic was, again re-implanted into, I think that fixed into sclera. But sometime if other haptic also come in, I think then you have to do the same thing for the opposite haptic.
That's true, sir. Only thing is that what happens that sometimes the blue haptic very mildly, very lightly shows through the scleral flap. So sometimes you get to know that okay, the haptic is there in position. The slight blue color, blue tinge is
Most important
visible.
thing is centration of the IOL.
That's true, sir.
That while you just take the haptic out,
Sir.
it should be perfectly centered while you go in.
Sir.
That centration is extremely
Yes, sir.
important.
Yes, sir. Another thing is that the amount of the haptic that has to be tucked also, you have to titrate it to see that it is well centered. If you tuck it more or tuck it less, again there will be risk of decentration. Yeah.
During your second case, how are you maintaining the anterior chamber, right? There was no maintainer, I think, in that.
No, actually it's an editor. In 100% of my cases I use, not 100%, in some of the cases I do use pars plana also, but in most of the cases wherein it's not vitrictomized, I use AC maintainer. So maybe it was just, it slipped out.
Visco also you can manage?
We can manage with visco because in such cases you can inject viscoelastic, and because you are not opening the anterior chamber. So I don't exactly remember whether I had used visco or it used AC maintainer, but if you are doing a plain routine SFIOL or glued IOL, then I use AC maintainer in 90% of cases. And in such case, you can inject viscoelastic from a stab. And since you are not opening the corneal wound, so it will remain there and you can easily take it out. And then you can remove with the bimanual IA.
Thank you very much, Dr. Rajesh, for showing these wonderful
Thank
cases.
you, and
I'll-
I'm sorry for barging in and asking you to accommodate within this time.
No, 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 no.
We are going to stay here.
Thank you so much. So next I'll request Dr. Jagatram sir to please show his case and 5 minutes. So I think Dr. Rajesh has shown wonderful cases, and for ICL the tip which he has shown is very important, that you need to rotate your hands while you are implanting ICL, so it prevents it from flipping upside down. So I always take care of the 3 holes which are there. So if you see those 3 holes going left side, you rotate your hand like this. Always try to keep these 3 holes in a straight line. That way you always can prevent its flipping. But he's a high volume surgeon, we all know in RPC, so complacent, if once you become little complacent, it happens. It can happen, yes. And you should know how to deal with it, yeah. That's the best way to deal with this. And so Dr. Jagatram sir needs no introduction. I think the number of video awards which Dr. Jagatram sir has won for India at international platform is amazing and huge. And we all like to see his wonderful videos every time. It's not coming here, his feed.
Start. Thank you, Dr. Harshul. I think this program is excellent program because here we deal with the tough cases, and where complication occurs, we deal with such situations. I think it is not there. आपका नहीं आ रहा ना उधर नहीं आ रहा. यहाँ तो है मतलब कनेक्ट है. तो मैक तो आप कनेक्ट करोगे ना? कल तो आया था, कल तो देयर वाज नो इशू। अब हाँ कुछ हो रहा है, अब आएगा। चलो अब शुरू से करें। I think the case which I am going to show is has grade 4 to 5, very very hard black, almost close to black cataract. That is one issue. Second issue was he was expected because pupillary dilatation was also less. So that was the second challenge. Third thing is that the patient was on treatment for prostate enlargement, and I expected floppy iris syndrome. So I expected these three problem. I was aware about it. So in this case, I did continuous curvilinear capsulorhexis, and then it was very very hard cataract. Here you see it was a after pupillary dilatation was this much which could be achieved, and suddenly pupillary dilatation came down. So this is just coming down here, and with best I think energy now you can see that this is almost 2.5 millimeter, and after even disco visc and other viscoelastic substance it is not coming up. So I thought that no way out than to place these iris hooks, and iris hooks was placed. So you can see how dense is this cataract, and I was prepared for disco visc or other viscoelastic substance to coat the endothelium, because endothelial damage is one of the challenge in these cases. And then anyhow I could fracture the nucleus. So I think success depends on that whether you can fracture the nucleus or not, and then making multiple chops. That was the other thing which I did here. But now I was not hesitant to complete this surgery, because already I have placed the hooks. But in between this cataract was very hard, almost more than 80% power with the white star. I was repeatedly putting viscoelastic into anterior chamber. So here I was very confident that okay, I will be able to complete it. This patient had bilateral similar hard cataract. So in this case I was well prepared, and this is the last nuclear piece here. So you have to be very very gentle, and then removal of the cortex from the capsular bag, and then of course I think it was not an issue to complete the surgery. And now implantation of the IOL, of course the hydrophobic acrylic IOL, this is implanted into capsular bag. So the purpose of showing this case was that it was a very hard cataract, and pupillary dilatation was also not adequate, and what to do if people comes down during surgery. And third is then floppy iris. So that was the point of discussion. I will like to ask the audience and my discussant that how can you do different this case.
Thank you so much, sir,
what I did
for showing this wonderful case to all of us. Dr. Rajesh, seeing the case with black cataract, small pupil to start with, and the floppy iris, patient is of course on tamsulosin. How would you plan this case? Like straight away go with expander and this, or what is your approach?
If it's if I know that he is on tamsulosin and pupil has not dilated well, maybe initial stage only I would like to go for a pupil expander so that it helps me. But many times what happens that we think that we can get away with, and that's how,
Yeah.
after sir has experience of
That is
innumerable-
what I thought, that I will
Yeah.
get away
Yeah.
with that floppy iris.
Absolutely. So in that situation, yes, putting the iris hooks is the best thing. Maybe one thing I would like to just add on to what sir told, that while if you are putting iris hooks in the middle of it, then it's better. I mean, sir must have done it. It's good to put viscoelastic behind the iris, so that the capsule falls back, the iris comes a little up, so that while putting the iris hooks, you don't catch the capsule. That is one. And sir, any reason, was it a high myope and with an expand series? Because what I could figure out that it was a multi-piece lens, slightly thicker one. I think it was a high myope, maybe 4 or 5 diopters.
Yeah, actually it was a high myope,
High myope,
patient, bilateral high myope,
Yeah.
and
That's why you're putting that multi-piece lens in the bag. It
Yeah,
must be
yeah.
an expand series lens.
Yeah.
That's why,
yeah.
Okay. Dr.
But
Kumar
sir,
wants to
very
add.
difficult case, very well managed.
Dr. Kumar wants to add something.
Sir, this was best in your hands only. Only one comment would be that the take-home message would be that when we put the 4 hooks, if you realize that the 2 hooks inferiorly were too far apart, and that brought the iris in the front, which may needed a 5th hook. What I like to do is I mark so that we make a perfect rectangle. And then if we put the hooks, then that iris which is coming where we phaco will not interfere.
Yeah, surely I think one can do as per your as per surgeon choice, that where you are more comfortable, and where it is uniformly placed. I think that is fine. That can be done, but other thing is, as Dr. Rajesh said, that we can place Malaysian ring or other Bhattacharya rings. Particularly, I think Malaysian ring act nicely, no?
Yeah, Harshvardhan?
Just add up a point. While making the 4 quadrants, instead of doing a direct chop, I would prefer to make a trench. And
Yeah,
then
yeah.
That,
No,
that makes the chopping much easier. Little just 2 or 3.
Yeah, surely I think
Yeah.
you are right.
Because in such gummy cataracts, it's very.
Both things you can do.
Yeah.
If you make a long deep groove, that makes the life easier. Once it is 2, then making it 4, 6, 8 is not difficult. That is one. But if it is little less hard, definitely direct chop can help. So that is one of the way.
Second
Yeah.
point I wanted to say, that after you finish the whole case, we tend to get excited. Oh, now I've done the cataract, and we try to do the the cortex removal really fast. That is the time you can get a rent. So that's
Yeah,
for
yeah.
the benefit of the junior. So
Yeah.
not to get excited even after finishing the main thing.
Yeah.
The job is still incomplete.
Yeah, it's not over till it's over. Yeah. Thank you so much, sir, for this wonderful case, and thank you, Dr. Rajesh. So next, I'll request Dr. Soumya from Coorg, and she's an prolific anterior segment and refractive surgeon, to present her case. Dr. Ashok, what's your choice of pupil expander nowadays? Can we have a mic to Dr. Ashok, please?
That's all right. I think I'm audible. It's a small room. I always prefer iris hooks, and that's convenient because you can choose where you would like to dilate. There are times where you would like to dilate to one side, especially in subluxural cases.
Yeah, yeah.
And you can put the hook closer to your wound area so that your iris get not near the wound. I use Soven's ring in case the iris is floppy. Otherwise, rigid irises, normally that's not very helpful.
Right, right. Thank you so much. Are you ready? Yeah. So Dr. Soumya with her case.
Thank you, Dr. Harshal. Most importantly for bringing us all together today, and also for making me a part of the session, and a big thanks to Scientific Committee IOC as well. So this is a small pupil. It was sub 5.5 millimeters on examination, and after block it has dilated a little bit. This is also a case where we've planned a toric IOL. So I have decided, although it has dilated a little bit after block, I've decided to go ahead with my plan of putting iris hooks, because I think the most important thing is that the surgeon should be stress free, because we need to be alive for longer to operate on more patients. So I like to make sure my life is simple and as less complicated as possible. So this is also a long-standing glaucoma, and the patient is on medication for prostate, and it's a grade 4 nucleus. So I have gone ahead with my plan. I have done the toric marking, and then I go ahead and put my iris hooks. So I, for the longest time, was using 4 hooks, and again, with my new concept of making my life less stressful, I have now moved on to using 5 hooks for almost all cases. Mostly because with 4 hooks, there's always an area where you have to go slightly under the pupil to do rhexis. And I thought it's best that I have, as much visualization as possible. So I have now moved to 5 hooks for all my small pupils. And 1 hook, like you can see, is just under the main wound. This is so that when we're going in and out with our phaco probe, it is not damaging the iris in any way. I have now started with my rhexis. If you pay close attention, you can see there's some amount of zonular laxity. So the whole bag is moving slightly when I'm doing the rhexis, which means there is some amount of zonular laxity in this case. And especially in hard cataracts, I always like to put a CTR if I feel there's any sort of zonular laxity. So now this is not necessarily a case of subluxation like you can see, but there is some zonular weakness. So my plan here, it was not planned for a CTR, but because there is some amount of weakness, I have decided to go ahead and put a CTR. So after hydrodissection, I then fill the AC with visco. I load my CTR and go ahead and implant it. Here the position of CTR is not very important because there is no gross subluxation per se. So as long as the CTR goes into the bag and stretches the bag out, it becomes more safer for us to operate. So with the injectors, you can actually also make sure the whole CTR goes in without even bringing the injector out. But in this case, I had to slightly dial it. Like you can see, it's a hard nucleus. But because I have the CTR in place, it has made my life slightly more simpler. And then we go ahead and make the chop. In case of bulky nucleus, I always prefer to debulk it by removing at least a small piece of segment initially. Although classically, we've all been taught that we should make sure we make our trenches and make our 4 quadrants and then bring it out. But I always prefer to debulk the nucleus so that dialing and even appreciating the depth of your chop becomes more easier and more simpler for us as surgeons. So once the first bit is out, the rest of it is more, it's regular just like any cataract, then you can go ahead and remove the rest of it. And now I'm going to irrigation and aspiration for cortex removal. And even here you can see that there is some movement of the bag, just to emphasize on my point of being careful about zonular weakness and how it can complicate and make our life more simpler if we use a CTR at the right time. So I've gone ahead and removed the cortex, and now because I've used iris hooks, my pupil has remained in place. And I can see my marking. It's a toric IOL. It's an Alcon toric IOL. So I go ahead, implant it, and then dial it into position. Here, probably because of the parallax, it seems like it's a little off, but it is in position. I dial it. Another thing that I do with when I'm not very happy with the bag is that I avoid cleaning too much under the IOL. I avoid taking my irrigation under the IOL. Instead, I prefer to let fluid waves run from under the rhexis so that a lot of it can come, just like we do the hydro, like we do a hydro dissection. I use my fluid waves to clean up under the IOL so that it's as less trauma to the zonule as possible. And then, of course, we close the eye and, wait for the next day to be happy about the post-op.
Thank you so much, Soumya, for showing this wonderful case. It was very nicely managed, very meticulous surgery. I'll request Dr. Ashok Nanda to give comment.
Yeah, that was very nicely managed. Of course, the only thing is that since you are using iris hooks and putting a toric lens clad, and as you said, you already not have washed the visco.
Yes, like I said, I take a lot of time to wash. So this is obviously an edited video. I take a lot of time to wash, but I do let fluid waves run until I'm sure that it is clear.
So in case you're not able to tap, you're not able to wash below, then at least you should make sure that you're constantly tapping the antisurface lens and let the
Yeah.
lens go back onto the booster capsule and allow the viscoelastics to come out before you actually end the case.
And what about timing of CTR? Looking at the amount of the laxity while she is making capsulorhexis.
Yeah, probably I would have waited. There's no hurry in putting it at the beginning. Looking at the amount of zonular zonulus that you have. But yes, that is up to a surgeon. Surgeon, you
Yes.
can put it at any stage. If you
Yes.
are comfortable putting it at the beginning, it's fine. Absolutely, there's nothing wrong in that.
Fine. Jagatram sir?
I think this is very nicely done case. And one question is regarding CTR, whether CTR to be placed or one can wait. But if surgeon is the best judge, that if surgeon is thinks that it is a subluxation, definitely I think as you place CTR, that should be done. That is one. And otherwise, you have done excellent job.
Thank you, sir. I just like to point out about the CTR is it's not only because of the subluxation, but also it makes the surgery simpler because the zonule is, it goes back and the capsule is tauter. So for me, the phaco itself becomes more meticulous and more easier because there's no tilt, there's lesser tilt when I'm doing the maneuvers, especially because this is a grade 4 nucleus. If it was a soft nucleus, I may not have put it. But in hard cataracts,
It's the rotation of the nucleus which is a little difficult if this is the CTR before.
sure, yeah. Which
Yeah.
is why I debulked it and then it becomes more simpler.
No, as Jagatram sir said that it's definitely depend on the surgeon's
Surgeon,
choice, and
absolutely,
you are the better, you are the best judge because we can only see two-dimensional and whatever is there.
Yeah.
You can feel it, what is
The
going
best,
on.
Best judge,
Yes.
but otherwise, in such situation, I would have not put it.
Yeah.
But if suppose I feel that as you felt,
Yeah.
if I also feel, I will also feel.
Yes.
Correct, sir.
But otherwise, in this case, I thought that I will not place.
One could manage without a CTR, but if I always prefer to be
Yes,
extra
yeah,
careful,
good.
so I would just, if I were to do this again, and if I had the same kind of movement, I would still put a CTR because I don't want at some point to regret that I didn't put it, just before my
So you
nucleus
should not
removal.
regret
Anything
later
in
on if
life.
there is a complication.
It's a very, very nicely and meticulous done surgery. Yeah,
Thank you,
no
thank you.
point of regretting. We are just
absolutely.
yes. Thank you so much, Soumya, for showing this case. Next, I'll request Dr. Harshvardhan to show his case. Dr. Harshvardhan is a prolific anterior segment and refractive surgeon from Mumbai, and I think the Henderson kind of CTR is still not available with us, no? The Henderson CTR which has undulations in it, because the cortex removal becomes easier with that kind of ring.
Yeah.
Yes, Harshvardhan.
So my case was actually old trauma with zonular dialysis, almost 180, not 180, little less than 180, and I thought of going ahead with the surgery and wanted to I thought I'll get away with a CTR ring and do the surgery. So old history of trauma, but on table I realized that the patient, the lens was not rotating, it had adhesions between the lens and the capsule, and we did not have capsular hooks at that time to hold the capsule back in order to rotate the lens. So this is just a on table decision to take this approach. It may not be really ideal, but so what we did was we started with the temporal, and then because the lens was not rotating due to adhesions and were not able to hold the capsule back, we decided to do a second port at 90 degrees and also used continuous viscoelastic irrigation to put the vitreous behind it, which was trying to come up through the zonular dialysis area. So just wanted to illustrate this.
This is a case of zonular dialysis between 4 to 9 o'clock in the primary position. This is the first main port which is temporarily placed. The insertion of the ECR ring is complete. We perform hydrodissection. Now we perform phacoemulsification. By the phaco-chop technique, we divide the nucleus into two halves and complete the division with the help of two instruments like the Sinskey hook. Now we approach the piece on the right, which is accessible from this port, and emulsify it. One half of the nucleus is now emulsified. We try to emulsify the second half. However, we are not able to approach it. We try to rotate it, but there we can see the big zonal dialysis and the nucleus does not rotate. So we rotate ourselves. That is, we change the position and come superiorly now. This is the second port, superiorly. And now we are able to approach the second half of the nucleus very easily, chop it into pieces and emulsify them one by one. Now you can see we have replaced the Sinskey hook with a continuous injection of a viscoelastic on the left. This maintains the size of the bag and we are able to emulsify the pieces in the pupillary plane. This is a very important step. Now we come to the last piece. It is slowly rotated and emulsified. Once again we use a continuous irrigation of the viscoelastic, as you can see on the left, to maintain the bag, which is trying to come into the phacoemulsification handpiece. Slowly we complete the emulsification with the bag in place and the pupil circular. Now we inject the intraocular lens under a good viscocohesive viscoelastic. The lens is placed very nicely in the bag and the pupil is made circular. This is irrigation aspiration done carefully and hydration of the two ports. This is superior and this is the temporal. Thus we have described a novel two main port phaco technique for a case of zonular dialysis. Thank you.
Jagatram sir.
I think it is well done case. It is, I think, perfectly done.
So-
it may not be ideal actually to make two ports, but if the
No, 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 no,
nucleus is adhered-
Harshvardhan, I also showed this technique in Bob Osher's symposium in 2011 for posterior polar cataract, where we never want to rotate the nucleus. So many times it's because we can't do adequate hydrodissection, so that portion doesn't, rotate and come down
Because the trauma
towards
case,
this.
maybe
Yeah.
adhesions also, as he said, ECR ring may not be allowing
Yes,
it to rotate.
yes,
so
yes. So I also showed, because I use 1.8 millimeter incision, so 1.8 is not big, not like 2.2, 2.4. So it's not something which is, it's very good that you can use two ports sometimes to get away with in these kind of situations.
Thank you.
Yeah.
What I mean to say, it is a very viable option.
Yes.
No, viable alternative.
Yes.
So what other options are there?
I can maybe use a capsular hook and hold the bag, and then maybe it will become easier.
Capsular bag support
Yeah.
will not help anyway. See here, since you have put a CTR, what you have done is probably you have done should have done a visco dissection.
Acha, okay. Yeah.
So you have already removed a piece. So there is ample space. So this ample space, all that you have to do is put some viscoelastic in the area of adhesion where you feel it's not rotating. Put it below that. It will loosen the nucleus or endonucleus part at least. So then that you would have made it simpler.
Uh, I think I'll just quickly show my case and we'll finish this session. So, as you can see, this is the case which had subluxation more than 4 to 6 o'clock hours. And there is a thick fibrotic anterior capsule also along with this subluxation. So a lot of troubles in this case. So after staining anterior capsule, I start making capsulorhexis. So you need to cut with micro scissors, and in the areas where the capsule is not fibrotic, I'm trying to make capsulorhexis with micro forceps going from the side port. And once I reach to the fibrotic area, I remember that if you try to pull through these fibrotic area, the rhexis may run in the periphery. So you need to cut with scissors in these kind of areas. So I use bimanual technique, change your hands wherever needed. And again coming to the subluxation area here. So you need to have this good 1.5 2 millimeter of margin because you need to put capsular hook in this area, and for that you need good rim of anterior capsulorhexis there. So take care of that. And again going through another side port, I cut through this fibrotic area, and this completes the capsulorhexis. Now we need to put this viscoat which is put there in the area of subluxation, and after that first you need to stabilize capsular bag before you can start phaco. So I go ahead and put 3 capsular hooks. So it's always better to use the devices which are meant for the purpose because they have longer this band there which goes till equator, and it supports better than iris hooks. So you can use iris hooks if you don't have capsular hooks, but it's always better to have these in your armamentarium. So once you stabilize this area, then this is the brittle cataract, and you can very easily take this cataract out. Remember that we always need to maintain the closed chamber space so that there is no collapse of capsular bag and there is no vitreous herniation there. So once I complete the nucleus phacoemulsification, I go ahead and put viscoelastic through side port before withdrawing my phaco probe. So always maintain anterior chamber. And once it's done, so then I realized that the role of these capsular hooks is over now. So we need to put a CTR ring to give equatorial support to the capsular bag. So I take off these capsular hooks and go ahead and put CTR ring through side port. And it's always better if you can guide this through the another Kuglins hook there. And once you have the CTR ring, you can see that the capsular bag gets stabilized and it gets stretched, and because all the forces get distributed from the area of weakness to the area where it's stronger. And now I'm just doing cortical irrigation aspiration. So you need to take off all the cortical matter which is there. And now because the subluxation is more than 4 o'clock hours, we need to stabilize the capsular bag to the scleral wall. So either you can use Sioni CTR, there's one CTR which will serve the purpose. I find it very easier to use CTS. So this is a capsular tension segment. It has an eyelet which pops out of the capsulorhexis margin. So you put a 90 proline suture in this eyelet and put it in capsular bag, and this loop comes out. So once you have, and then you railroad it, either you can use a Hoffman pocket or I made a scleral groove here. And you just use, this is a 28 gauge needle which I'm using, 28 or 30 gauge needle as I'm using to railroad this 90 proline. So once you railroad both the arms of Prolene suture, then you can tie this to scleral wall to the appropriate tension, so that now once you have fixed the capsular bag in equatorial as well as anteroposteriorly, it's good to hold the single piece acrylic IOL. So here the single piece acrylic IOL, it goes in capsular bag, and you wash off all the viscoelastics, and that completes the case. So this was the case I wanted to share. Any comments or suggestion? Yes, sir.
Excellent, beautifully done case. Why? Because there is a fibrosis of the capsule.
Yeah.
Another problem is it is a grossly subluxated cataract.
Yes,
So
sir.
both the things were managed very well.
Yeah. Yeah, Harshvardhan.
It's also important to make the CCC in such a way that when you pull the back,
Yes.
come in the center.
Yes. So in subluxated cataract, you should always try to center it over the lens, not over the. Yeah. So I think any other questions, or we'll close this session, because next session is about to start. So thank you each and everyone for presenting your cases, and thanks a lot for contributing. Thank you so much.
I would like to thank Dr. Harshul for this very nice series of going at stuff. It really good learning experience for everyone. And thank you for the opportunity. Thank you.
So, welcome to next session. So, ISMSA session. For this